Afternoon and welcome to the IIEA, and a very special welcome to our guest speaker today, who is Dr. Mike Ryan, the Executive Director of the WHO Health Emergencies Programme. The event today is sponsored by Irish Aid, which is celebrating has celebrated its 50th anniversary this year. And before we begin today's proceedings, I'm going to give the floor to Michael Gaffey of Irish Aid to say a few words. Michael.
Thank you very much, Mary, and it's great to see you again. And it's really a great honor to just briefly introduce our lecture today, or our conversation today, shall we say, which is the Deputy Director General of the World Health Organization and Executive Director for the Health Emergencies Programme, our own Dr. Mike Ryan. This is the last in this year's Development Matters lectures, which is it's a series that Irish Aid sponsors with the IIEA. And I have to say that I think this year we're ending on a very high note with Mike Ryan, but I think it has been one of the best. It has been probably the best year of lectures that we've had with the IIEA. And I just want to pay tribute and thanks to Jill Donoghue and to researcher Tara Kukic for their work on this series. Last year, Director General Tedros and Mike Ryan came to Ireland and participated in a series of events to mark the renewal of our partnership with WHO. And it was really clear, as if we hadn't realised it, that Mike was an absolute household name in Ireland. Wherever he went in that visit, he was recognised. And that's because of his work during COVID primarily. But he has actually worked everywhere there has been a health emergency, be it Ebola or Marburg, cholera, polio or COVID. And we are really proud that so many Irish people, including Mike, have made their mark in the fight against these existential challenges. And I just want to, on this occasion, pay special tribute to a good friend of Mike's, Aidan O'Leary, who was in charge of polio eradication in the World Health Organization and who died far too soon and suddenly in August of this year. Aidan made a real difference, and we should dedicate the fight to finally eradicate polio globally to his memory. Under Mike's leadership, we've seen highly organised and effective health responses in some of the world's most challenging environments, including Ukraine, Gaza and Lebanon. And every humanitarian crisis is a health crisis. Over the course of 2024, 144 million people have required health assistance. And that's due to conflict in Ukraine, Gaza, Lebanon, Sudan, or as a result of drought and severe food insecurity in Africa. And now we look with renewed uncertainty at the situation in the Middle East as it transforms in whatever direction due to events in Syria. So to conclude, we all know we live in dangerous and unpredictable times with interlocking crises, all in the context of the existential threat of climate change. And this challenges how we work and how we view our work. So our discussion today is as timely as it is necessary, and we are very keen to hear from you, Mike, on the challenges of protecting health in a world of crisis. You're very welcome, and we look forward to this conversation. Thanks.
Thank you, Michael. Just a few housekeeping matters at first. The format this afternoon will be 20 minutes discussion, followed by Q&A. Please, you, the audience, feel free to join in using the Q&A function on your screen. Both the presentations or the conversation and the Q&A are on the record. Feel free to join the discussion on Twitter using the handle @IIEA and #DevelopmentMatters. We are also live streaming this afternoon's discussion, so a warm welcome to all of you tuning in via YouTube. Mike, can you give us some sense of what are the really most urgent issues on your desk today at the end of 2024?
Mission that you gave there to Aidan O'Leary. He was a dear friend who died way too young, survived by his wife Karen and his son Dara and daughter Emer. It was a huge loss to the polio community, to the humanitarian community, to the Irish military, to his family, to the people of Galway. So tremendous loss to deal with, and dedicate whatever the rest of polio eradication and what we do today to his memory. So, yes, I was checking this morning about the number of events we're tracking around the world. I think it was 367 as of this morning, but we have 41 graded emergencies, and they're emergencies that require, by our grading system, a formal WHO response. In other words, boots on the ground, WHO responding with partners. And they will range from what we see today in Syria, which is a massive displacement of people. And while we're very joyous for the people of Syria maybe having a chance at a more stable and peaceful future, the reality is that there are millions of people displaced now all across Syria. There are refugees returning from other countries. There are still hotly contested areas in which civilians are moving through. We've seen many attacks on healthcare over the last 6-7 days. And so that's at one end of the scale. At the other end of the scale, we're investigating a very, very severe cluster of unexplained deaths, mainly amongst children in southern DR Congo, where the zone of the suspected epidemic is 2 full days 4-wheel drive away from the nearest airfield. So on the one hand, investigating, a potentially very serious epidemic disease, and on the other hand, responding to a rapidly unfolding humanitarian crisis, and pretty much everything in between.
Thanks, Mike. When you have a situation like Syria, which was certainly unpredictable in its speed, how does the WHO even begin to scale up in that context?
A good question. I think, first of all, for us as the World Health Organization, we're there before, during, and after crisis, because we have a relationship with our member states. So we've always been in Syria, so we always have had a presence. We've operated on a whole of Syria basis over the last 10 or more years, in which we see Syria as one zone. We've operated both from Damascus and Gaziantep in Turkey, supporting the people affected in northwest Syria and the people affected in greater Syria from 2 zones of operation. That's worked for us up to now. Scaling that up now, and the needs have definitely scaled up. We'll have to surge staff in from outside. We will have to enhance the capability of our partners and try and get our partners to deploy on the ground in the health cluster. So part of it will be direct surge. Part of it will be asking our partners to scale up at the same time, and then really investing in the local system. I mean, the one thing that Syria does have, and many countries have, is an inherently competent medical, nursing, and other systems. Very often, people have become disconnected from the system. Infrastructure has been damaged. But many countries, particularly in the Middle East, have proud, historically strong health services. What has happened is those health services have been hugely disrupted by conflict, by displacement, and by direct attacks on healthcare. So a lot of our work is to recreate the infrastructure in which people can return, where their salaries can be paid. So the solutions aren't external in as much as they are the external entities have to create the conditions in which local health staff can return to work, in which the local system can start to reignite and re-engage local services. And that's the hard part, because it's very easy to look at an external solution where everyone arrives with help and we have all the flags flying, and that's great for the first few weeks. It's great for the first few months, but that doesn't last forever. So you really have to switch as quickly as you can into a recovery phase where you can start to rebuild the existing inherent health service. And that link between the humanitarian response and the development response, which some people call a nexus between the two, is one area that's really not functioning as well as it needs to function globally. The humanitarians are exhausted. They're exhausted responding. Our development partners are obviously very nervous about getting involved in humanitarian and conflict situations in which it's very difficult to do sustainable development work. But unfortunately, there are so many countries right now affected by fragility, conflict, and vulnerability around the world. And we were doing some work with the UN Ops people, looking at how many people will live in contexts of fragility, conflict, and vulnerability by 2030. And, it will be 85% of the world's poorest people. Half the children who die under 5 will die in those settings. 65%, 2/3 of women who die in childbirth will die in those settings. Half the under 5 mortality will occur in those settings. We think 60-70% of high impact epidemics will occur in those settings. So these contexts of chronic fragility, conflict, vulnerability, where sort of the 3 C's of climate, contagion, and conflict are just intertwined. And I think Michael used a good word, interlocking crises. And I think that's the context we're looking at. A whole series of countries that seem to be separating from the rest of the world. Many, many countries that were otherwise known as developing are moving on in their development cycle. They're making gains in education. They're making gains in health. Maybe their political systems are not what the West would approve of, or whatever it might be. But the reality is many, many countries are making progress in those basic metrics. It's those countries that seem to be just separating politically, socially, economically, religiously, and are being driven by this constant repeated crisis. And we have to do something about that, because that's driving displacement, that's driving migration, that's driving desperation. The people moving up through the Americas, or people moving across the Mediterranean, aren't doing it because they want to risk drowning in the Mediterranean. They're doing it because they're desperate. They're moving away from something that cannot sustain them or their families. And they're doing that for a reason. They're not risking their lives for no reason. So unless we deal with those drivers, then it will become, and continue to become, a major driver of not only instability in these countries in the coming months and years, but a major driver of instability in so-called stable states.
Just turning to the last time we spoke, it was exactly 2 years ago, and there was also in the Development Irish Aid lecture series, and the topic was then COVID. And in fact, it was the Omicron variant, if my memory is correct. What I want to ask you is, we all know COVID hasn't gone away, but what progress has been made in the WHO in dealing with the next great pandemic? Where are the negotiations at with the pandemic agreement? Do you expect it to be adopted in 2025? Is it important that it be adopted in 2025? And if not, if it isn't going to be adopted, then what are the problems?
That's a good question. I mean, the idea of having a strong pandemic agreement or accord underpins everything we need to do to get ready for the next pandemic. A piece of paper or an agreement or a piece of international legislation by itself doesn't change the world, but what it does is provide the basis. It provides the solemn agreement between member states on what we need to do. And actually, member states have made remarkable progress. I mean, yes, it's been reported how difficult it is, and it is difficult. These are important matters. You led 20 years ago the negotiations on revising the international health regulations, which hadn't been done in decades. And that revised IHR has underpinned our global surveillance, verification, risk assessment work, and our cooperation with member states on infectious diseases for 2 decades. And it's just been revised again. It takes, you went through that, you know what it takes to get 194 countries to agree on anything is tough. So there are a lot of issues, and there are issues in there around sovereignty. There are issues in there around intellectual property, around access and benefit sharing, around equity, around a lot of different things that are important on both North and South. So there are issues that need to be resolved, but I think they've made remarkable progress. For example, effectively, if you think about it, and you know, the audience may not know this as well, but the world of diplomacy seems to thrive on green text. You know, you have the green text that's been greened inside the actual draft document. And it's remarkable, a lot of work. There's the articles on research are green. The article on health workforce is green. There are articles on supply chain that are almost green. So there are key areas where we need to work together on ensuring we have a scalable workforce in future, ensuring we've got strong collaborative surveillance, on ensuring we've got good community protection, on ensuring that we have countermeasures available to everyone. Those key elements of the agreement are in place. There are some specific issues that do need to be resolved, especially around the access and benefit sharing system. There are some issues around intellectual property. There are some issues about how detailed should the treaty be around issues of prevention and issues of risk reduction for the emergence of epidemics. And the 12th meeting of the IMB took place last week. I think we're reasonably pleased with their progress. The prospect next year is very good. In a normal sort of geopolitical environment, you would imagine that the countries are approaching consensus. You know, it's never there until it's there, but they are approaching consensus. But the world is a bit fractured right now geopolitically, so it's very hard to predict. There are question marks over multilateral systems, you know, this nationalism versus multilateralism. And the reality for me is that the greatest definition of your sovereignty as a nation is your ability to engage with other nations confidently on matters of common interest. We do it in trade. We do it, we trust each other. We wouldn't be able to move or trade unless we had agreements on how to do that. Well, if we can't agree on what to do for the next pandemic, then that is a real tragedy for the planet. It's a tragedy for the next generation. We need to have the basic rules of the game in place. It won't be perfect, nothing ever is. But without such an agreement, we are going to go into the next pandemic with no playbook. And that is not a good idea.
Well, the glass is either half full or half empty, but I suppose the missing ingredient is always political will, and hopefully the political will is there because, as we all know, disease doesn't stop at borders. Can I look at one of the known unknowns, as it were, to quote or misquote a US statesman? How important is strong cooperation from the new incoming US administration, the conclusion of the pandemic agreement?
I think strong participation. Well, first and foremost, throughout the whole process of negotiating the pandemic agreement thus far, I must say that all countries have remained very, very constructive in the process, and particularly the US has been very constructive, very direct, very sure of its position, very clear and honest around the red lines and areas where they want to see convergence, or they want to see a certain direction. So I've been very pleased with the way in which the USG has engaged in the pandemic agreement. It again will come down to each and every sovereign state. When a final agreement text is put to the member states at the World Health Assembly, it will be up to each member state to decide whether or not it's willing to adopt the agreement and then engage in a conference of the parties and decide what further work will need to be done. Because at the end of the day, a pandemic agreement is a very short document. It is essentially a series of aspirations and promises to do other things, like build a strong system for access and benefits, to build a strong mechanism for training workforce, to build a strong supply chain for the future. The very act of writing an agreement doesn't make those things real. What it does is provides a blueprint for that. And I'm sure from for example, the US's perspective, we rely heavily on the United States for a tremendous amount of technical cooperation, scientific cooperation. In exchange for all of that, we at WHO provide to all member states the kind of intelligence. Like today, the reason why, if we're talking about the outbreak investigations we have around the world, we're putting them on our secure website for our member states. They can see exactly what we see going on around the world, be it in the jungles of southern Congo to what's happening in Syria. So our ability to gather and add value to public health intelligence, to be on the ground as eyes and ears, to respond and put out fires before they become out of control. These are things I think we share those values with the US. I think in general, the pandemic agreement adds to the body of law in this area, mainly as represented by the international health regulations. I think all sort of reasonable thinking people would see that. The question is, where does the consensus lie? How far does the agreement go? Is it going too far for some, not far enough for others? And that's going to be the balance. I'm confident that when we look at issues of global security, there are other areas where it's harder for us to agree on certain things. But when it comes to the idea of how do we ensure our global health security, then I do believe the vast majority of member states agree that there really is only one platform to do that through comprehensively, and that's through the World Health Organization as a specialized agency of the United Nations. There's lots of speculation, Mary, around the US this, what will the US do, what it won't do. What I know is I've worked for 25, 30 years in the front line. I've stood in the trenches with many American colleagues there and many American institutions. We need the US to really work and ensure that we have a strong global health protection architecture, that the global health emergency architecture is strong. If one of those key partners is not there, that makes it weaker, there's no question. If that partner is not there, we have to get on with that and cut our cloth. But the world is a much safer place with a strong United States supporting things like the pandemic agreement, supporting the international health regulations, supporting global health security. And I fervently hope that they will continue to do that in 2025.
Mike, I just want to reference one specific crisis, and that is the conflict in Sudan. What exactly, could you give us an update on what is happening there and what the main concerns you would have are in that area?
Yeah, I mean, it's terrible. Sudan is the forgotten crisis of any. I mean, it's been entirely overshadowed. And not, I mean, what's happened in Ukraine, what's happened in Palestine, what's happening in Syria are all very important and deserve their appropriate attention. But what's happened in Sudan has essentially escaped the true attention of the world. We need to keep it in the global spotlight. And thank you so much, Mary, for raising that specific area, that geography, because the security situation is highly volatile there. There are huge issues on bureaucratic administrative delays in working in the country. There's frequent denials for access to key areas. We have lots of other things happening beyond the conflict. We have heavy rains and flooding, damaging roads, reduced access because of that. So it's not just a conflict crisis. We've got drought in some parts, flooding in another part. Again, a poster child for that climate contagion and conflict issue. We've got various outbreaks. I could start naming the different epidemics that we're tracking. And then you've got this real big problem of protection of health workers, attacks on healthcare, and really, and this is the same across many conflicts, the fact that we have so many attacks on healthcare, either on healthcare infrastructure, healthcare personnel, healthcare transport like ambulances, that it's becoming the fact that so many are doing this with total impunity. I'm not aware of a single person, institution, country, or anybody who's ever been held to account for attacking healthcare, ever. And since we've been doing this for a number of years now, but since 2000, over the last 5 years, we've well over 5,000 documented, verified attacks on healthcare. So this is really happening very much in Sudan too. We've had 65 attacks on healthcare this year, resulting in 167 deaths and 95 injuries. That's in the healthcare facilities, right? That's not outside. So to give you an idea of the extent to which all of this is happening. The other huge concern, I mean, obviously, nutrition has been a major concern. We've been at near famine status for so long. It's incredible. The resilience of the Sudanese people is beyond measure. Gender-based violence, sexualized violence is rampant, and something, again, that's not triggering the international community, in my view, in the way it should be. So I think if you want to look at a given crisis in the world for depth and breadth in terms of geography, population affected, in terms of the intensity of the crisis, the number of different types of crises that are happening at one time, Sudan is where it's at. And yet it's got the least attention, even today, it's got the least political attention to find solutions. And there are many countries involved, in, I would call it, in the proxy efforts, supporting one side, supporting the other side, a lot of manipulation going on geopolitically in the process as well. So when you're humanitarians or local NGOs or you're the local health system, trying to exist and survive in that situation, it's incredibly difficult to do that. The distances in Sudan are huge. The population is massive. The displacement is huge as well. And it's almost a problem that it's too hard to get your head around at times. It's so big, and yet it's not getting the attention it needs. Ireland is doing that, I know, but others need to step up and step in, because I don't see a greater humanitarian crisis on the planet right now. Even the crisis in Syria, while it may be very severe and there's a lot of population movement, in terms of human impact right now, there is no greater crisis on this planet than what's happening in Sudan.
Is this failure to focus on Sudan or do anything, is this partly reflecting the vacuum that's there at the Security Council, that there is no overseeing body with the authority to say, let's get serious about this problem?
Well, I'll leave that now to you and Michael, the real diplomats, to sort out, right? But
I think you've just answered the question. But before going over,
it's exactly the same thing when it comes to attacks on healthcare. You know, the reality is that the humanitarians are out there doing their work. We will continue to do our work. It's not our job to be political, but it is the job of the political architecture of the United Nations to create the space in which humanitarian assistance can be delivered, and to create the space in which recovery can occur and populations can have their peace, stability, health and education returned. By any measure, the Security Council system is not delivering on that. Now, it was always a difficult task. It was never easy. Sitting in and trying to get countries who are otherwise geopolitically or ideologically at odds with each other to work together is not easy. It was never an easy job. But whether the job itself is getting more difficult or whether we're getting worse at doing the job, I leave it to you to work out.
Thank you, Mike. I'd like to encourage the audience to put in some questions. I can't see them myself yet, but before giving the floor to those joining us online, there's one final question I want to ask, and it's a question with two parts. The first part is that the World Health Summit in 2024 had as its main theme, building trust for a healthier world. Is there a problem in the global south in this area? That's the first question. And then the question of trust in science, trust in vaccines. Is there a problem in the global north in that area? How do you see the issue of trust as it affects your work?
Yeah, I think there are major issues of trust across the board, but I don't think it's north-south there. I think there are nuances with north and south. It's hard to speak about it in that terms, but in general, I can see it in terms of equity. There is a breakdown in trust. I think in general, and you're saying this in a very generalized way, the countries of the south, and wasn't always of the south, felt that certainly during the pandemic they did not get a fair share of access to the countermeasures that were coming online and being available, and that's created a sense of a two-tier system. There's a system for the north and there's a system for the south, and that feeds into similar experiences during HIV/AIDS, where again the availability of countermeasures was years, decades sometimes behind. Now, in this particular case, equity came later, but maybe quicker than it did previously. That's why I think for the pandemic agreement, there's a real feeling amongst countries of the south that they want something they can trust. They want an agreement that lays things out in a way that they can trust that equity will be addressed systematically in any future pandemic, and that would be the trust issue north-south at the macro level when it comes to that. There's also a trust issue when it comes to climate and other things. I mean, this idea that in some ways by 2030, if we don't keep the temperatures down below 1.5 degree increase, we're going to have some consequences of climate. I mean, that's rubbish. The fact is there are hundreds of millions of people in the Sahel and the Horn of Africa and in other places, in Mozambique and other places, that are literally suffering the massive impacts of climate now. They have the droughts, they have the floods. It's way beyond what anyone expects. They are living the climate nightmare already. And again, the trust issue is when we have green climate funds and all kinds of funds, and we see the spectacle of the negotiations that happened most recently in Azerbaijan, where we're fighting over what will be mitigation funds for developing countries. It's hard for them to actually trust when there's such a nickel and diming going on funding. So I do think there's a trust issue in general around things like that. Is the North actually serious about assisting the South on real issues that are existentially and affecting the ability of the global South to get out of humanitarian crisis, to deal with the climate crisis, to engage and sort of ignite their development, or at least accelerate their development in the right direction? I think that's a big trust issue right now. In terms of trust in science and vaccination, I think that's universal. I don't think that's a North-South issue. I think that's happening everywhere on the planet. There are different drivers of that. It's really worrying. It's really upsetting, quite frankly. For example, vaccination has saved more lives on this planet than every doctor put together with every nurse, put together with every hospital, put together with every CAT scan and every surgical procedure we could ever do. Hundreds of millions of lives saved by vaccines. Simply the most effective health intervention that's ever been designed by humans. That's a reality. Now, that doesn't mean that those interventions don't need to be carefully monitored, properly regulated, always safe, always tested. That's the process. What's happened is that the question marks over the safety of these, the conspiracies around why these things are produced, why they're being used, have really entered the mainstream. They were always there. And quite honestly, Mary, if I'm a parent, or even for myself, I'm going to question anything I put in my child's body, drug or vaccine. Healthy skepticism, hesitancy is not a bad thing. To hesitate before you make an important decision is not bad. It's not, as long as that hesitation is then followed by questioning and gathering of information, good information that allows someone to make a good decision. So I think we've left, quite frankly, I think public health and science, and we in policy and public services have left a vacuum into which disinformation, misinformation, and conspiracy theories have filled that vacuum. I don't think we've been fast enough, quick enough, agile enough in engaging with communities on their genuine concerns around science and drugs and vaccines. And in many ways, I think we need to get better at our job rather than criticizing those who are spreading a lack of faith or a distrust in science or a distrust in vaccination. That's always been there. It's just being amplified through social media. And if we think that's going to disappear and all of a sudden people doing that are going to have some kind of conversion and say, we've been wrong all this time, we're going to stop doing this, is rubbish. That is going to continue. It is going to get worse. We have got to engage with, first of all, our communities to convince them that our information and our data and our information is to be trusted. I think we still as well have to engage with many people who are sucked into the disinformation side. Many people who are engaged in that would not have those views if they had access to better information, or at least their views would moderate. But, you know, I don't think we're in a vaccination anti-vax world. I think reasonable questioning, considered hesitancy, there's nothing wrong with that. And I would hate to think that we're in a world where we're shoving things down people's throats or we're forcing people to do things that they don't want to do. That should never happen in a democratic society. But there is a societal concept. We operate as a society. We accept that we do certain things. We have speed limits on the road of whatever it is, 70 kilometers or 70, 80, 100 kilometers an hour on the motorway. We know if that speed limit was 60 kilometers an hour, there'll be a lot less deaths on the road. But at the same time, if that happens, then there's chaos. Nothing gets anywhere. So we constantly, as a society, balance the good against the evil. We have levels of contaminants of food that we accept and levels of contamination of food that we don't accept, because we know what's safe and what's unsafe. And I think that's the issue in society, is we've done that forever. The problem for people is they want to know more now. They don't just accept the decree of the scientists. They don't just accept the doctor, priest, policeman access anymore, right? The idea that we're told it's good and we're told it's safe, that should be good enough for you. That's gone. The era where people just accept the rote learning or our wisdom is gone. We need a new engagement with people, and they need to get access. They need to engage. They need to question us. They need to see that we're real and that we can engage in a conversation, that we know what we're talking about, that we're willing to engage the skeptic, we're willing to engage the critic, and we're confident in doing that. And I think it's been that lack of confident engagement that's hurt us. We've stood behind our own slogans of vaccination is safe or whatever it might be. Sorry, I'm going off a bit on this, Mary, but it's something I feel passionately about. That it's we're in a new world in which people consume information and decide on action using completely different parameters than we used in our generation before. Completely new, and we should be asking younger people, how do we combat anti-vaccination and anti-science? They probably have a much better idea than us.
No, thank you very much for that, because it is a problem that we all confront all of the time, and it's useful to get your perspective on it and not dismissing people's concerns. I think that's the message I got very clearly from you. Can I just take up some of the questions? And one here is, what is the impact of the Ukraine and Gaza crisis on emergency funding in other areas? Are you seeing an impact there?
Absolutely, yeah. And not that those two crises don't deserve a huge amount of support, but they have had a freezing effect. I mean, huge amounts of resources have gone into the Ukraine response, less into the Gaza response. It's really been the Ukraine response. It's created financial flows in the donors. It's not that the donors don't want to give money for other things. It's just that such a large proportion of the budget gets used in Ukraine that there's not a whole lot left to go around. And that's certainly, we've noticed that. Some donors have really tried to balance that and try to reduce the impact of that, but it's real, and it's always happened. There've always been areas where get more attention than other areas. That happens, but it's been quite acute, quite extreme in this particular case. So we have struggled. I mean, there are some humanitarian response plans where the health component are less than 30% funded. There are some that are less than 10% funded. I mean, it's really bad in certain geographies. So notwithstanding all we've had to do, we've had a tremendous amount to do in Ukraine. We've seen a huge, sort of impact on the health system, particularly in the areas of conflict. We've had to shore up the public health laboratory system, the surgical trauma system. We actually had pre-positioned surgical trauma equipment in Ukraine for more than a year before the latest invasion. We had trained surgeons all across the country. We've done lots of work, for example, on radionuclear disaster response and so many other things we've had to do through our regional office there. So it's not that we are fully engaged in Ukraine, but for example, Sudan and other crises have probably suffered. Not that, as I said, the overall humanitarian pie remains the same. The problem is it is a pie. It's not getting any bigger. So if one crisis gets more than another crisis, then the proportion the second crisis goes down. And we are struggling. We're struggling all over the world. We're struggling from Haiti all the way across to Afghanistan. It's doubly difficult in places like Afghanistan, Syria, and others, Yemen, where there's a perception that the regimes are not favorable to the West or have some ideologic difference. So therefore, it's been exceptionally difficult to get funding for our civilian humanitarian response in the likes of Syria, in Yemen, in Afghanistan. Again, because of this perception of ideologic difference, where Western donors are not as inclined to put money into those geographies as they would be in Ukraine or Gaza or somewhere else.
Can I just follow up on that very briefly? Is it a case that there's a fear by some donors that money would be misapplied? And what can you say to donors to say, no, if you contribute to our emergency funding appeal, that money will only go on health and will go in an even-handed manner to the health emergency?
That is a big concern for donors, and we do a lot of work on monitoring and evaluation and end user monitoring to be sure that our aid is getting straight down to the end user. Aid diversion is a real issue. You can't, it's a reality in many of these geographies. It's a reality everywhere. But where the aid diversion might go to someone who's ideologically opposed, then it's even more unacceptable. We've put in place a lot of arrangements around avoidance of aid diversion. But, in some of these geographies, some of these countries, it's almost impossible to make those guarantees. I mean, you're talking many situations where there's extreme lawlessness, where there's no centralized government architecture. And in those situations, it's quite difficult. The problem is that the civilians are still there. So what do you do? You've got millions of people that need assistance, but you're in a situation where you're not able to necessarily guarantee that every single vaccine, every single surgical piece of surgical equipment, every bandage will go to the hospital it's been directed at. And then particularly in the case of medical aid, that becomes an issue of whether or not that gets diverted for military use, in terms of treating combatants and other things. So food diversion is also a big issue for WFP and others. But I think we've put in place much more robust systems for doing that. And we're getting much better at doing that because we've had to get better, because we've had to demonstrate to donors that we can follow our particularly materials right the way down to the end user. But it is having a chilling effect on donor willingness to further engage and certainly to increase their funding without guarantees on aid diversion is very difficult.
There's a question here from Cormac Gallagher, and it's about the DRC, which you mentioned yourself at the beginning. And he asked that given the cluster of new or resurgent viruses across the DRC and the absence of capacity there to deal with basic health, what should be the priority for health there? Can I just add a little codicil to that? There always seem to be emergencies in that particular region. How far has the international community gone in helping to build up a basic health structure across the region?
Yeah, it sort of depends on the country, but if we take DR Congo as an example, I mean, DR Congo is a continent in its own right. I mean, it is absolutely, it's the size of Western Europe. It is huge, and it is very difficult to get around. Congo has suffered the tremendous after effects of colonialism, really, really destructive colonial interventions. And it's been fractured ever since through its own sort of failure to generate a kind of a sustained peaceful democracy over many, many, many generations. So it's not an easy place geographically, climatically, politically. It's a challenge. What I've always been amazed with is the essential resilience of the system and people's ability to keep going, particularly on the health side. I mean, the Institut National de la Recherche Biologique, INRB, it's their national research center, which is run by a mentor of mine, by Professor Jean-Jacques Mayembe. And Jean-Jacques and the team have worked there for more than 50 years. They've done some of the best scientific work. They discovered the Ebola virus. They're the ones who respond to all of these really important epidemics. And they've managed to keep their system going. They've managed to do some of the leading, cutting-edge research, cutting-edge containment activities. So when you look at individual examples, there's no lack of capacity in Congo. Congolese are really smart people. The issue is that integrity of a state built across such a wide diversity of ethnicities, wide diversity of languages, and been able to build that coherently over enough time to build those basic services of health and education. It's a challenge. It's a challenge. But there's no lack of inherent capacity. I've seen it. I've witnessed it. Some of the finest epidemiologists and public health practitioners working for WHO are Congolese. it's interesting to me, that contrast between what is the inherent ability of people versus the fact that there's a real challenge in creating a model of government that actually works for people in a country like DR Congo. I think Cormac just asked the question. I mean, there are huge issues of disease in Congo, but it's the common or gardener ones. It's not the exotics like Ebola and Marburg, which we see. It's malaria. It's measles. These diseases are killing thousands and thousands of kids in DR Congo. So leaving aside the exotic and all the stuff that we do in my program, the reality is it's the lack of basic preventive immunization, basic mother and child care, the very basics of a health system that protects young children from disease. That's what's really missing. The rates of maternal mortality are huge. The rates of child mortality are still huge. So Congo and other countries need a real switch towards primary healthcare, a real switch towards community-led primary healthcare services, right, that can deal with what really is killing people on the ground, and then move to a more sort of longer-term development of the health system. This westernized approach to health system development, I don't think it works in a country like Congo. I think we've got to invest much more in localized services, in bringing NGOs and others in with government to find ways to deliver services to people where local communities, non-governmental organizations, and the government can work together in a way that's adapted to the local sort of ethnic and sort of cultural sort of dynamics, and not have this cookie cutter approach, one size fits all. That's not what Congo is. It's a magnificent country, and I've spent many months, God knows years at this point, in Congo. It's also undone by the fact that it's got some of the largest natural reserves in the world, precious metals and other things, which, you know, leads to political and other interference that does the people of Congo no good. In reality, the people of Congo should be the wealthiest nation on earth. And the fact that they're not, to me, is really the tragedy of it all, you know.
I'm going to change the focus a little bit, because we've been focusing on what is wrong, what isn't working, where the emergencies are. Can you look back on the last 10, 15 years and think of a situation, a health emergency situation at the international, if not the global level, where you felt that the system worked well? I mean, you must have successes.
We do, and I would hate to think anyone going away from this discussion, walking away depressed, thinking, "Oh my God, Chicken Little, the sky's going to fall in," painting a picture of doom. There are loads of examples where, especially where you see community-led surveillance initiatives, where communities themselves can pick up signals of epidemics, where you have a rapid response to take samples and a containment exercise occurring. You don't hear about those outbreaks because they're small and they don't spread. So there are loads of examples of that. I actually, you know, from my perspective, you know, people don't need to be worried about, in Ireland particularly, don't need to be worried about, you know, the idea that some virus is going to emerge from nowhere and kill everyone on the planet. It's not the history of our species. The reality is that with proper public health measures, good surveillance, with the technologies we have at our disposal, we should be able to manage health crises from now and into the future. We have the capability to manage humanitarian health, the health component of humanitarian crisis. We've got very good at doing that with the health cluster, the 900 partners in the health cluster. We've become much better at responding to the health impacts of climate, the health impacts of conflict, and the health impacts of contagion. In fact, I think it's something we should all be very proud of. And what we should also be very proud of is the inherent resilience of communities that they can deal with all of this. So there's an awful lot about human ingenuity and human cooperation that is to be celebrated. The one thing will be that in the face of a major health crisis, that cooperation and that solidarity needs to be optimized to the nth degree. Because for example, in an epidemic crisis, things move very quickly. So if you're not fast, you get into trouble very, very quickly. So our ability to be agile, our ability to work with our communities to put in place the necessary mechanisms to detect and respond to these health crises, it's hugely important. And I think it's very doable. In fact, if you think about it, we managed to eliminate or eradicate smallpox 50 years ago. Polio is on the brink of being eradicated, and it would be a great tribute to the memory of a great Irishman, Aidan O'Leary, that it would get done in the next couple of years. And that's a prospect for other diseases in future as well. We have a real potential as a human race to really put infectious diseases behind us. But we're consistently failing at it. We're not using vaccines effectively. We're certainly not using antibiotics effectively. We're at risk of losing antibiotics as a major part of our healthcare response to infectious diseases. So we're squandering the gains of the last 100 years, not optimizing the gains. And that's what I'm really worried about. I think human beings are brilliant at finding solutions. Our problem is applying those solutions sustainably and applying those solutions with the care of every human being, where the whole 8 billion of us get the same access to that solution. That's what we're really bad at. We're very good at making new things. We're very bad at making sure that people who need those new things get them.
And, a final question, and this comes back to something that's been sort of there all in all of the answers you've given in some ways or other, and that is the climate crisis. It's here. I think you've already said that. It's not something to fear in the future. We need to fear it now. Can you give your perspective on how the climate crisis is already impacting on global health?
Yeah, no, it's having a major it's having a major impact, and that can be, you know, I mean, right across the all of the world. When you look at be it heat waves, brush fires, all of that stuff that we're seeing in the north, extra cold winters, or when we snowstorms, extra storms. But they're inconveniences in many ways for many societies in the north right now. Yes, they're terrible events, and they cause terrible heartache. But if you go to the south, where you're seeing you completely, like in the Sahel, a whole way of life, the pastoralist way of life, is being lost forever, as people who've relied on feeding animals and moving with those animals across the Sahel is just disappearing with the permanent droughts and floods and everything else that's happening. Those people are pushed into agriculturalist areas, and it's causing massive tensions between pastoralists and agriculturalists. That in itself is driving all kinds of other effects in those countries. So when you look to what's happened in the Sahel politically and from a security point of view, a lot of it can be traced back to the immediate impact of climate on the whole socio-cultural political dynamics of that whole region. This is where climate is really driving things, because it's driving a competition for land, a competition for water, a competition for resources that didn't necessarily exist at the level that's existed before. And I think that's going to be a major source of conflict if we talk about climate and conflict, right? But then if we talk about climate and contagion, we're seeing huge increases in cholera outbreaks. We have cholera outbreaks occurring in 31 countries. This is the pandemic. It's still a pandemic, right? That started in the 1960s, the El-Tor 7th pandemic of cholera. It never ended. It just stayed around at low levels. And now it's back with a vengeance, and we've had over 500,000 confirmed cases this year alone. Cholera is an ancient disease, and it is exceptionally climate sensitive. We're seeing huge increase, doubling, trebling in the numbers of dengue cases. Dengue, Arapuche virus, yellow fever, Zika, and chikungunya virus, all transmitted by the same vector, the Aedes aegypti mosquito, a mosquito that breeds generally in human-derived water waste, upturned tires, cans, very much in peri-urban sort of that peri-urban sort of environment where there's a lot of human water waste. Those epidemics are now biblical in nature. and they're overwhelming health systems. And the interesting thing in dengue is when you get your first infection with dengue, it's bad. When you get the second infection, most people think, oh, like something like any other disease, my second one will be milder. It's exactly the opposite in dengue. Your second infection is worse, and your third infection is even worse. So you actually end up in this paradoxical situation where each subsequent infection can be worse, and you may end up with hemorrhagic fever and having and dying from it. So all of those diseases, those vector-borne diseases, we're seeing shifts. If we look at mpox and other diseases in Africa, we don't know why those are likely to be rodent-borne diseases are re-emerging, but it's likely to be some form of climate impact on wildlife. And we're seeing huge stresses in the rainforest, huge stresses on wildlife, and that's bringing wildlife in closer contact with humans. So it's changing the dynamics of the relationship between humans and animals. So climate is affecting the animal-human interface. Climate is affecting the vector densities around the world. Climate is affecting waterborne diseases like cholera, and having a direct impact through things like heat waves and direct injury with floods and wildfires. We've never seen, for example, in southern Africa, Madagascar and Mozambique and southern Malawi and others were never affected by seasonal hurricanes. Each winter for the last 2-3 years, we've had these massive tropical cyclones come in. They've caused huge flooding, followed by cholera outbreaks. So we've had this cycle of cholera and flooding and cholera, and it's been worse in areas of conflict in the north of Mozambique, where we've got a difficult sort of conflict situation. So that's one area where that climate conflict contagion sort of maelstrom, that whirlpool, is very, very active. So I think the idea that the impact of climate is coming if we don't do something is, unfortunately, it's past history. It's here, and communities need immediate assistance to deal with the impacts of that. And it's not that expensive to do, but it's not happening right now.
Well, thank you very much, Mike. The hour is up. I think I could go on for another hour, but you can't, because you have much more important things that we all want you to be doing. Can I wish you the best and the WHO for next year? And as we were talking, I was thinking your success is our success. So let me wish you every success for the future.
Thank you, Mary. And I don't know if people in Ireland are fully aware of the role you played in international and global health security. You were the chair of the body that negotiated the revision to the international health regulations all those 20 years ago, that was responding to the re-emergence of all those diseases like SARS, like H5N1 at that time, like Ebola. And the response of the international community was to try and revise the international health regulations to make them fit for purpose for the 21st century. And you did that. And we've benefited for that from the last 20 years. And try to interpret the meaning and the constitutional sort of intent of our member states through that time. So if anyone has contributed to global health security as a senior diplomatic level, Ireland has, and particularly for your leadership, Mary. So thank you for that. We've benefited from it, and we hope we get this pandemic agreement over the line. There have been days I wished you were there to whip them into the line, but we haven't had you. So thanks so much for the work you've done as well.
Thank you very much.